Welcome to the deep dive. Today we're jumping into a concept you hear all the time in healthcare talks. Value.
Mhm.
Sounds simple enough, maybe. But as we're going to find out, it's actually really complex. There's no single definition everyone agrees on.
Not at all. And that lack of agreement, that ambiguity, it really has huge effects on how healthcare systems get reformed, how they actually work day to day.
Absolutely. And for you listening in, maybe wanting to get a solid handle on this pretty crucial idea without, getting bogged down in jargon.
Right.
Well, that's what we're here for.
Exactly. Consider this your shortcut to understanding something that's frankly fundamental to where healthcare is heading.
So we've been digging into a really fascinating paper. It's called What Do We Mean by Values in Healthcare? The Importance of Reaching a Consensus. It's by Joachim Sternberg and Saadi Taher.
And it really unpacks the different ways people look at value in healthcare, all the different lenses.
Our goal today, to pull out the key insights from this paper. What are we really talking about when we say value in healthcare?
And maybe even more critical, why does it matter so much that we understand these different views if we want a system that actually works well for people?
We've got some surprising history to touch on and some really great real-world examples that make it all much clearer.
Definitely. Should be interesting.
Okay, let's dive right in then. The first thing that really jumps out is just how loaded that word value is.
Hmm.
The authors call it problematically value-laden, which I think nails it.
Yeah, it means our own judgments, our biases, they're kind of baked right into the definition from the start.
Which is a huge point to begin with,
Yeah.
because when we talk value in healthcare, it's not just about money.
Not at all.
Yeah.
There are these fundamentally different ways of framing it. The paper highlights two main camps, you could say.
Yeah.
Business and economics on one side.
Right, the usual suspects, efficiency, ROI, profit.
Exactly. And then on the other side, a more humanistic frame.
And that humanistic side isn't just one thing either, is it? It's got layers.
Precisely. It splits into two main branches. You've got the ethical side that's more personal stuff like
Mhm.
autonomy, being authentic, benevolence, respect, resilience, how we operate as individuals.
Oh.
And then there's the social dimension. That's about working together effectively, so collaboration, commitment, equity, resilience again, respect, sustainability,
Yeah.
how the group functions.
So our own mental frames, like our personal outlooks, our worldviews, they really shape what we see as valuable.
Totally. Whether you prioritize money or power or control or maybe mindfulness or your social responsibilities,
Yeah.
it all stems from that frame.
And the paper says these frames need to be frame coherent. What does that mean exactly?
It means we feel uncomfortable if our actions or the system we're in clash too much with our core beliefs. It's that cognitive dissonance idea.
Okay. Like if a system is purely about cost cutting, but the staff feel they can't give good care, that's a clash.
That's a perfect example. It creates real tension.
Now, the paper makes this distinction, which seems important, between healthcare and the healthcare system. It sounds like semantics, but it's not.
No, it's crucial.
Yeah.
Healthcare is the face-to-face stuff, right? Attending to a patient's needs right there and then.
Doctor-patient interaction, basically.
But the healthcare system is the whole big structure behind it. The policies, the buildings, the professionals, the funding streams, the IT, everything needed to enable that care.
And for that whole system to work, to actually get the results patients want, there have to be some kind of shared agreement socially about what value means.
That seems to be the argument. It needs a value proposition that benefits society broadly.
Because healthcare produces this common good, as they put it. It's bigger than just one person's financial gain or satisfaction.
Exactly. The values inherent in healthcare are connected. They're systemic. You can't really isolate them.
Okay, systemic. That's the key word here. We can't just look at the pieces separately. This leads us to thinking about the healthcare system as a system in that scientific sense.
Right. And the big idea there is that a system is a whole. You can't understand it just by taking it apart.
Everything's connected, interdependent.
Yeah. What happens in one part affects all the other parts. Nothing acts entirely on its own.
And systems sit inside bigger systems. Like a clinic is part of a regional network, which is part of a national system.
Exactly. And inside the clinic, you have subsystems like how appointments are made.
And each part, big or small, needs to kind of align its behavior with the main goal of the whole thing.
If it doesn't, you get problems. If one department is just chasing its own numbers and those numbers don't actually help the overall mission, well, it doesn't work.
Okay, this is where it gets really fascinating for me. The paper says the properties of the whole system don't exist in the individual parts.
Right. You can study one doctor or one policy inside out, but that won't tell you how the entire system behaves.
That's the complex adaptive systems idea, or CAS, emergence.
Exactly.
Yeah.
Emergence. The system does things, shows behaviors that you just couldn't predict from the components alone, like that classic example of a flock of birds.
Ah, yeah, how they move together without a leader.
Precisely. No single bird is in charge, but the flock's movement is incredibly complex and coordinated.
And they use this vortex metaphor, like a whirlpool, to explain a CIS. Can you break that down?
Sure. So picture a vortex. It has that center point, the focus, that's the system's purpose.
Okay.
Then you have the water itself, all interconnected. That's the flexible structure, the parts linked together.
Right.
The way the water swirls, how movement in one area affects others, that's the interdependency, the information flow up and down.
Got it.
And a vortex is pretty resilient, right?
Yeah.
You poke it, it tends to reform. That's its robustness. It can handle disturbances.
So the health system is this constantly swirling, adapting thing.
In a way, yes. And the paper adds another layer.
Yeah.
It's a socially constructed, functionally layered system.
Okay, what does that mean?
Well, think about how organizations grow. Maybe it started small, like one doctor's office, a one-man show.
Mm-hmm.
But as it gets bigger, you add departments, billing, nursing, labs, functional units.
And that's where the problems can start.
Potentially, yeah.
Mm.
Each unit might develop its own goals, its own little silo, and maybe lose sight of the big picture, the main purpose of the whole organization. That can lead to what they call dysfunctional behaviors.
Misaligned incentives, maybe. Poor communication.
All of that. Information doesn't flow properly. People doing the work might not see how it connects to the overall goals. And this leads to this really powerful quote.
Which one?
All organizational systems are perfectly designed to get the results they get.
Ooh, okay. Let that sink in.
Yeah.
So, if you don't like the results your healthcare system is producing, look at the design. It's not just bad luck or a few bad apples.
Exactly. The structure, how it functions, the context it operates in, they all determine the outcome. And often, when we try to fix just one bit in isolation, without thinking about how it connects to everything else, we can actually make things worse. We forget those interdependencies.
This is a perfect bridge to how value fits into this system's view, because the paper points out this common mistake. People equate increasing value with just quality improvement.
Right. And that's a crucial distinction, because your values actually decide what kind of quality you're even trying to achieve. It's not neutral.
And they contrast two big names here, Donald Berwick and Michael Porter, their takes on value.
Let's start with Berwick, back in '92.
Okay. What was his angle?
Berwick said value comes from a systemic organization of care. He argued you first have to define the purpose of healthcare.
Which he said was?
To preserve, restore, and improve the health of our patients. For him, value wasn't just about one interaction. It was about how the whole system worked together for that purpose.
And it wasn't just doctors and hospitals for him, was it? It was broader.
Much broader. He included things like education, social supports, anything that impacts health. The patient was truly at the center.
So leadership, in his view, was about making sure the system met all the patient's needs.
Absolutely. And he talked about needing transformative leadership, especially somewhere like the U.S. with its business focus. Leadership that listens to the community, understands the broad needs, and gets funding aligned with that core purpose.
Okay, now shift to Porter. His definition is probably more widely known, maybe.
Possibly. Porter defines value as outcomes that matter to patients, divided by or relative to the costs involved.
Outcomes over costs.
Yeah.
And he had specific steps, right?
Yes, 6 main steps. Things like organizing care around conditions, not just specialties, measuring costs and outcomes for every patient, using bundled prices.
Integrating care, expanding reach, using IT.
Exactly. It's a very structured approach.
Yeah.
The key insight is that focus on measurable results tied directly to cost. Efficiency.
Definitely sounds practical, aimed at efficiency, but the paper notes a potential gap. Just doing those steps doesn't automatically tell you what actually matters to a specific patient.
That's the critique. Porter acknowledges you need changes in thinking, in structure, but the framework itself doesn't inherently define what matters. That's still subjective.
He did try to define patient value, though, right? Things like health status, time, complications, suffering, sustainability.
Yes, and suggested measuring functional status as a way to capture it.
But the paper pushes back on that, too.
Yeah, arguing that functional status, while objective, might not capture the whole picture of what's truly valuable to that individual in their life context. What's a good outcome for one person might not be for another. It's highly context sensitive.
Which brings us to that sort of simple formula. V equals Q plus S cost. Value equals quality plus service over cost. Sounds neat, but
It's flawed, hugely. First, how do you even measure quality? It has so many dimensions, you can't just put one number on it easily.
and the cost thing.
Right. The economist Uwe Reinhardt made this point forcefully. Cost doesn't determine value. Just because something is expensive doesn't mean it delivers better outcomes for the patient.
Makes sense. A pricey procedure doesn't automatically mean better health. Now, what about the big organizations like the OECD? They look at it mainly through an economic lens.
Largely, yes. Focusing on costs, who pays. This often leads to things like performance targets, DRGs, those fixed payments per diagnosis.
Right.
And the paper suggests these cost containment strategies can sometimes get in the way of delivering what matters because they push efficiency metrics over individual patient needs. There's real tension there.
And this economic view can miss the bigger picture, right? That healthcare is an investment in society, not just a cost.
Exactly. That broader societal benefit, healthier workforce, more community participation, gets lost in a narrow cost calculation. And there's evidence suggesting that too much focus on just the economics can actually harm quality and outcomes.
But there's another perspective. The European Commission expert panel has a different take on value-based healthcare rooted in solidarity.
Yes, a much broader view. They talk about 4 pillars of value.
Okay, what are they?
First, personal value, getting the right care for your goals. Second, technical value, best outcomes possible with the resources you have.
Makes sense.
Third, allocative value, distributing resources fairly across everyone.
Right.
Equity. And fourth, societal value, healthcare's role in helping people participate in society, feel connected.
Wow, that's much more comprehensive. It sounds a lot like what the U.S. National Academies reported on global quality, too.
It aligns very closely. It's a holistic view. The insight is that value isn't just clinical. It's about equity, society, the whole person.
Which brings us back to this core idea. For a system to work, it needs a clear purpose and shared core values.
Absolutely. Purpose and values are tied together. They have to be.
And these aren't just nice words on a poster. They need to be fundamental guiding principles.
Exactly. Things you stick to even when it's tough. They're the foundation for solving problems and have to align with the system's purpose if you want real, lasting improvement.
Defining them sounds hard, though. We all have personal values.
It is tricky. The paper mentions Collins and Porras, who had these 3 questions for organizations defining core values.
Oh, yeah. What were they?
1. Will this value still hold true in 100 years? 2. Would we keep this value even if it put us at a disadvantage competitively?
Wow.
And 3. What values would we want in any organization we built, no matter the industry? Really forces you to dig deep.
Those are tough questions. And in healthcare, you have so many players, patients, doctors, hospitals, insurers, government, all with potentially different ideas about purpose and value.
Precisely. Getting agreement among all those stakeholders on the system's main purpose and core values is essential for it to function as a coherent, complex, adaptive system. Remember Deming, without an aim, there is no system.
Right. No shared goal, no real system. So leadership is key here, to bring people together.
Crucial. Visionary leadership is needed to guide that conversation. Keep reminding everyone how their actions affect others. Find that common ground.
Because even with different perspectives, business, social, ethical, there needs to be some shared agreement on priorities, like access, quality, equity, how resources are used.
Yes. And they use that vortex metaphor again. All the stakeholders are like smaller whirlpools within the big one. They all need to align with the main purpose and values for the whole thing to work smoothly.
Okay, so if we look at a health system's results, we can kind of work backward to see the values driving it. The paper outlines 4 different system orientations.
Yeah, points on a spectrum, really. Not rigid boxes, but useful for seeing how values shape the system. And financing often plays a big role.
How so? Like how doctors get paid influences things.
Definitely. Fee for service, for example, where you get paid for each thing you do. And to attract specialists. Often higher income, maybe less uncertainty and focus.
Okay. Whereas outcomes-based payments?
Might appeal more to generalists, primary care docs, people comfortable managing a wider range of issues, maybe less focused purely on maximizing income, more on the overall patient result.
And there's that point about cognitive load, too, the mental effort involved.
Right. Specialists often have a narrower focus, which can mean less cognitive strain compared to a GP, juggling dozens of different conditions and complex patients all day.
Which links to burnout risk, especially for generalists. That's a system issue.
Absolutely. needs to be considered in how we design things.
So let's look at the payment models themselves. Fee for service, F4S, capitation, fixed fee per patient, pay for performance, P4P, outcomes-based. They all push things in slightly different directions, intentionally or not.
Exactly. F4S encourages volume. Outcomes-based encourages, well, outcomes, but can be complex to manage. And different groups, doctors, insurers, patients, might prefer different systems based on their own interests.
The paper outlines a sort of underlying purpose of each. F4S is often about finding and fixing specific diseases, but yeah, it incentivizes doing more.
Capitation, DRGs, P4P, often driven by cost control, might lead to prioritizing patients likely to show quick benefit, sticking rigidly to schedules, maybe less flexibility.
Whereas outcomes models push towards really understanding the patient's illness experience, working together for their definition of quality of life.
And you can see the different values underneath. F4S aligns more with business economic values, autonomy, competition. Capitation and the like lean more towards ethical social values, equity, maybe justice.
It's interesting how this connects back to older ideas, even ancient Greek medicine, the split between focusing on the disease versus the person with the disease.
Absolutely. And modern philosophical debates too, individualism versus social equity. These tensions run deep.
And the paper argues that the system's design often reflects the designer's mind frame.
Yes. Their underlying beliefs and values shape the purpose and structure. It's a cycle. Mind frame shapes values, shapes system orientation, shapes outcomes.
So what happens when a system is built mainly on a business value frame? What does that look like?
Typically, it's grounded in free markets, individual choice. It can work well for specific, defined market segments. It kind of encourages market segmentation and care.
Tends to favor the narrow, specialist, single disease approach. Less whole person care.
Often, yes. And it frequently adopts a prescriptive approach. Lots of guidelines, protocols. Maybe less comfortable dealing with patient complexity or uncertainty.
And the evidence it values.
Tends to prioritize randomized controlled trials, the gold standard. Medical training might focus heavily on disease facts and technical skills. And organizationally, it often leads to command and control management. Efficiency is key.
Okay. Now, contrast that with a system based on a humanistic value frame.
That system values the whole person, physical, social, emotional, cognitive needs. It embraces different kinds of research to get that richer, contextual understanding of illness.
Medical training would be different too.
Yeah, maybe emphasizing why patients present differently, the interdependencies. The doctor-patient conversation focuses more on listening, making sense together.
Shared decision-making becomes central, aiming for the patient's best quality of life.
Exactly. And leadership is more flexible, empowering people to adapt, not just follow rigid rules.
Yeah.
Collaboration and relationships are key.
So there's a figure in the paper that lays this out visually, right? How the different frames drive different system elements.
Yes, figure 4. It shows how business values lead to more process management focus, while humanistic values lead to more consultation integration relationship focus. Understanding both is crucial if we want a shared path forward.
And the key point isn't that one is right and one is wrong.
No, not inherently, but each frame has built-in consequences across the whole system. We need to really think about those consequences before we make big changes based on one frame or the other.
So putting it all together, how do we get to lasting value-based improvement? It sounds like it has to be systemic.
It absolutely does. All these pieces, values, orientation, leadership, they're all linked. Values decide what matters and how we try to achieve what matters.
And the foundation is systems thinking, recognizing everything's connected. Change one thing, you affect everything. No quick fixes in isolation.
And recognizing context. Remember Virchow. So many health problems come from outside the clinic, social issues, environment.
Injustice, discrimination, unhealthy environments.
All of it. So redesigning the system means embracing that complexity, the complex nature of health itself, of how services are organized, of the system's goals, of leadership. Systems thinking is the only way to get care that's safe, effective, person-centered, accessible, timely, affordable, efficient, and equitable. It's a tall order.
And our definition of health needs to be systemic too, beyond just no disease.
Yes. That SPSS frame, physical, social, emotional, cognitive. Health is complex, adaptive. Think of that patient quote.
I know I'm dying, but why do I feel so healthy?
Exactly. It shows health isn't just about the disease label. It's about the person's overall experience and well-being.
Such a powerful point. And how services are set up. That comes down to values and money, which links to leadership decisions.
Right. And the paper strongly argues healthcare is mostly a common good, not just a business.
Because being a patient isn't usually a choice. The word itself means vulnerable.
And the system shouldn't exploit that vulnerability, especially for the disadvantaged.
The system's overall focus matters to person-centered primary care versus disease-focused specialists.
And the evidence suggests strong primary care often does just as well on specific diseases, handles more complexity, gives better experiences, and costs less overall.
Which loops back to leadership needing that systems and complexity view, uniting people around shared purpose and values, adapting based on feedback, balancing all the competing demands.
It's a tough balancing act. Systemic leadership.
The paper gives some great real-world examples of this working.
Yeah, 4 really interesting ones, different places, different scales, but all focused on what matters most to the patient.
First up, Mayo Clinic.
Right, built on that core value. Needs of the patient come first. Streamlined, collaborative care. And they even set up a foundation to reinvest profits back into patient care. Value-driving structure.
Then EDARP in Nairobi, started focused on IVAIDs.
But listen to patients and providers. Added TB care, prevention, social support. Their values fostered collaboration, and they built a whole primary care system where there wasn't one. It grew organically from need.
And NUK in Alaska. That's fascinating, earned by the indigenous community.
Yeah. The community defines the core values: wellness, respectful care, access. Leadership constantly asks for feedback and changes things based on it. High satisfaction, better health outcomes.
And finally, Costa Rica, a whole country example.
Single-payer system, designed way back in '41 to guarantee population health. Then in the '90s, they shifted hard to a primary care-led model. 5 pillars: integration, teams, defined populations, measurement, digital tools.
And the results.
Big improvements in access, quality, outcomes.
These examples really drive it home when you truly center the system on patient needs as the core value.
You can get better outcomes, happier staff, even economic sustainability. Look at Costa Rica, better health, lower cost compared to many others.
So it seems like the leadership piece is absolutely critical. Leaders who get the complexity, who move away from rigid hierarchies.
Towards more adaptive generative models that understand the local context. Because so much of healthcare is still very top-down, protocol-driven.
Right.
But real value often comes from adapting to the situation on the ground.
So the big takeaway isn't some magic formula for value.
No single formula. It's about embracing systems thinking, having systemic leadership focused on patient outcomes, being sensitive to context, always adapting, collaborating, and seeing healthcare as a long-term investment in people.
Okay. To wrap up our deep dive then, we've seen value in healthcare is, well, it's complicated.
Definitely not simple.
It spans everything from business efficiency to deep humanistic needs. Understanding those different angles and seeing the system as this interconnected web is vital. And it seems the power of shared values, truly putting the patient at the center, is key to making systems work better and more fairly for everyone.
Hopefully, digging into these ideas give you, the listener, a stronger framework for understanding all the talk about healthcare reform and what value-based really means or should mean.
And maybe a final thought to leave you with today. Take a moment and consider, what would your core values be for the healthcare system you'd want?
Yeah, how do your personal values stack up against the business or humanistic frames we talked about?
And thinking about those examples, Mayo, Eduque, Costa Rica, what lessons can we draw from them, even if our own context is totally different?
Lots to think about. It's a crucial conversation.
Absolutely. Thanks for taking this deep dive with us.